Hello, it's a pleasure to be with you today. We're going to talk about how to implement new standards of care in multimodality management of stage 1 to 3 EGFR mutant non small cell lung cancer. I'm David Jones, Professor in Chief of Thoracic Surgery at Memorial Sloan Kettering, and my co moderator is Nathan Pinnell, who is Director of the Lung Cancer Medical Oncology Program and a lung cancer medical oncologist at the Cleveland Clinic. Here's the agenda for today's program. We're first going to talk a little bit about the progress to date and what some of the unmet needs are, as well as opportunities for improvement. And then we're going to have some candid conversations about precision lung cancer care for thoracic surgeons and the multidisciplinary teams that they're a part of. And we'll focus really on the evolving role of EGFR targeted therapy in early stages of lung cancer and why we do that now, what some of the key trials and data are, as well as what the implications are for thoracic surgeons. We'll then talk about clinical consults and multidisciplinary care, kind of best practices as they stand today for our patients who have early stage resected lung cancer. And this will focus a large part in integrating tyrosine kinase inhibitors or targeted therapies into multimodality therapy. Um, and then we'll have some reflections, we'll do a few case studies, and then have some take home points. So I'm going to begin and talk a little bit about what the progress to date has been, as well as unmet needs and some opportunities for improvement. First, I want to talk a little bit about biomarker testing demands and targeted therapy options for lung adenocarcinoma. As you can see here in this paper published in 2017 in Cancer Discovery by Jordan et al., here are the number of genomic perturbations that have been identified in lung adenocarcinoma. And to the right, you can see what the target is, and then the various approved drugs. And right now, including new approvals for EGFR exon 20, those are nine uh, genomic perturbations that are, in fact, targetable with drugs that are available. Almost all of them in late stage and metastatic disease. You could probably include HER2 in this category as well, which is not listed. But a lot of opportunities increasingly for us to think about the role that targeted therapies, including therapies for EGFR mutant lung adenocarcinoma, may play in our patients potentially. But there are some gaps in biomarker testing in non-small cell lung cancer. If you look to the left at My Lung Consortium, you can see that if you were to see how well we're doing with biomarker testing looking at EGFR, we're actually doing not too badly, but still 25% of patients are not getting their tumors tested for EGFR mutant status. About the same for ALK. And then if you look about all five biomarker studies, which would be EGFR, ALK, ROS1, BRAF, and PD-L1, we're less than 50%. So this is not great. And these are on resected specimens. I can imagine that it's even going to be more challenging to have numbers in the 80 percentile range, et cetera, when we're thinking about neoadjuvant studies. The Flatiron electronic health record data shows a very similar story. Again, that we're still missing the overall mark and a lot of opportunities here. The one thing the Flatiron data does also show us is that there's some notable disparities, statistically significant between testing in white or Caucasian versus Black or African American. So another opportunity for us to be focused on. Well, with all this biomarker testing, is there any role for potentially an early stage lung cancer now that we know that we have targeted therapies available to us? And I would just say that the data we have right now suggests that in the adjuvant setting, it really depends on the stage, with the largest benefit being seen in patients who have more local regionally advanced disease. And if you focused on the last set of data at the bottom of the slide, the LACE analysis, you can see that the benefit, if you will, of adjuvant therapy is very minimal, about 3% for stage 1B. And this is adjuvant doublet cisplatin-based chemotherapy. It improves to maybe 10% in stage 2 and up to 13% in stage 3, which is why that is and remains an NCCN directed guideline for adjuvant therapy for those patients who have pathologic stage 2 or stage 3 disease. So at this point, I'm going to turn it over to my colleague, Nate, to go ahead and talk a little bit about the evolving role of EGFR targeted therapies in early stages of lung cancer. Nate?
Thanks. I'm excited to be able to talk a little bit about some of the progress that we've been making in targeted therapies in the adjuvant setting. As David so astutely pointed out, there's lots of opportunities for improvement in the benefits of adjuvant treatment in patients at high risk of recurrence. And interestingly, of course, for more than a decade in the EGFR mutation positive patient space in stage 4, we actually haven't been preferentially using chemotherapy. We've been using EGFR targeted therapies preferentially. So why is it only recently that we've gotten to the point where we're using this in the adjuvant space? So we're going to cover a little bit of the history behind this and then the current data that has given us our first approved therapy in this space. If we look at EGFR mutations, these have been known for a while. The ones that are most important for targeting are deletions and insertions in exon 19, as well as point mutations in exon 21, and most of the therapies are targeted at this population. If you look at the history of EGFR mutations, the first discovery that these were meaningful mutations that predicted benefit to targeted therapies was in 2004 when 3 different groups independently published on this set. However, there were a number of years where there were still debates about the most appropriate biomarkers for patients with non-small cell lung cancer and whether EGFR mutations truly were the most meaningful biomarker. The IPASS study in 2008 really put this to rest, showing that it was EGFR mutations that were really predicting benefit from the tyrosine kinase inhibitors as opposed to just the clinical phenotype of non-smokers with adenocarcinoma. Since then, we've seen a number of developments in terms of the development of second-generation EGFR TKIs and then third-generation TKIs and their benefit for people with T790M mutations. And then finally, in 2016, we saw the approval of osimertinib, the third-generation EGFR inhibitor, for first-line treatment. Since then, we've had continued development of other agents, investigation of combinations in EGFR and VEGF, which hasn't yet really worked its way into standard of care yet. But what we're going to focus on today was in 2020, we had our first approval of adjuvant osimertinib for EGFR mutation positive patients. And where did we get, or how did we get to that space? Well, it's helpful to think a little bit about why we might want to give adjuvant chemotherapy, and there's several things that can happen to people in this space. And when you start to see what the results are, I like to keep these in my mind. So what we hope is that people with remaining microscopic metastatic disease will be cured with this effective systemic therapy. But we also know that there may be people who aren't cured, but are still just being treated, and the cancer is being suppressed and their recurrence delayed, such that if you have a time-limited treatment and you stop it, they may then go on to recur despite the treatment. And then finally, we have to always remember that surgery does cure people with non-small cell lung cancer. And so when you're giving adjuvant therapy, necessarily people are going to be overtreated and receive treatment when they don't really need it. So you have to keep this in mind as well. If we go back to the era where we weren't quite sure what the most appropriate biomarker was in the non-small cell lung cancer space, to the RADIANT study, which enrolled people with EGFR expression and not mutation specifically, we saw that erlotinib versus placebo and given in the adjuvant setting did not improve disease-free survival or overall survival. But in the subgroup of people with EGFR mutations, there was a significant difference in disease-free survival in patients who received erlotinib versus placebo. Although ultimately in this small subgroup, this didn't lead to an improvement in overall survival. There were single-arm prospective studies of EGFR mutation-positive early-stage patients who received 2 years of adjuvant erlotinib, such as the SELECT trial here. You can see that there was an impressive 5-year disease-free survival in the overall population of greater than 50%. Which was similar across different stages. However, single-arm studies really can't prove to you whether this is better than placebo or treating at recurrence. And so we really needed randomized trials to answer this question. The first randomized trial that was presented was the CTONG or Adjuvant study of resected stage 2 or 3A patients who were treated with either adjuvant gefitinib, the first generation EGFR TKI, versus cisplatin vinorelbine. And this was just for 2 years. And importantly, this was either or. You were randomized to either the TKI or chemotherapy, which is an interesting decision because we know for stage 2 and 3A patients that there is a meaningful survival benefit from chemotherapy. So certainly a higher bar to cross. And there was, just like in the subgroup of RADIANT, a meaningful difference in disease-free survival in favor of gefitinib. But you can see that by 3 years, since the treatment was only given for 2 years, the two curves come together. And ultimately, there was, again, not a difference in overall survival, leaving us, again, with not clear evidence that the first generation TKIs were meaningful and should be used in the adjuvant setting. So this brings us to probably the most important trial in this space, which is the ADAURA study. This was a phase 3 study for resected 1B, stage 2 or 3A non-small cell lung cancer patients with the common sensitizing mutations, exon 19 or exon 21 point mutations in EGFR. Patients were then randomly assigned to osimertinib, the third generation EGFR TKI, for 3 years, whereas previous studies had used 2 years of treatment, versus placebo, with a primary endpoint of disease-free survival. In 2020, at the ASCO oral presentations, we saw that in an interim analysis with only 2 years of follow-up, they had released the data early because what they'd found on interim analysis is that there was already a huge difference in disease-free survival, even very early on in the study. For the primary endpoint population of stage 2 and 3A patients, you can see that disease-free survival was 90% in the osimertinib arm at 2 years, compared to only 44% in the placebo arm. And if you included the entire intent to treat population, you can see that it was 53% in the placebo versus 89% overall. This was felt to be important enough to release this data early, although importantly, the study does continue unblinded, or that it is blinded for the participants and they are continuing on for therapy. So this will be very important to update as it goes forward. If you look at the characteristics, you can see that disease-free survival favored the osimertinib arm across every group. You can see the stage 1B patients perhaps a little bit less, but that makes sense because stage 1B patients have a lower risk of recurrence. Clearly, in the placebo arm, the risk of recurrence was highly stage related, with increased recurrence as it gets higher. Importantly, though, in the osimertinib arm, the recurrence rate was basically the same at about 90% in all 3 arms. The disease-free survival according to whether they got adjuvant chemotherapy. So in this design, it's very important to point out that patients were offered adjuvant chemotherapy if appropriate for their stage, although not every patient received adjuvant chemotherapy, and we're going to go over that a little bit more later on in this talk. But there was no meaningful difference whether they got chemotherapy or not, and patients with and without adjuvant chemo still benefit from adjuvant osimertinib. Whenever we're talking about an adjuvant trial, when we're giving someone a drug for multiple years, it's very important to look at the toxicity and see how well this is tolerated. But interestingly, there were not significant meaningful differences in adverse events between the 2 arms, except in the grade 1 category. There were a few grade 3 toxicities, 1% to 2%, and things like diarrhea or paronychia. Grade 2s were really not significantly different between the 2. There was, however, more grade 1 diarrhea, dry skin, compared to the placebo arm. So later on, we're going to talk a little bit about whether we think this meaningfully impacted quality of life. So in conclusion, adjuvant osimertinib was the first targeted agent in a global trial to show a statistically significant, and I would argue a clinically meaningful improvement in disease-free survival in patients with stage 1B, 2, and 3A EGFR mutant non-small cell lung cancer. The improvement in disease-free survival was seen regardless of whether they'd gotten prior adjuvant chemotherapy, and the safety profile was very consistent with what has previously been known with osimertinib, which is the standard of care for advanced stage patients. Importantly, this trial, even though, again, a very early follow-up was found to be significant enough that the FDA did approve osimertinib with accelerated approval after resection for patients with exon 19 or exon 21 EGFR mutations as detected by an FDA-approved test. So there was an awful lot of discussion about this trial when it first came out, and again when osimertinib was approved. And I think the biggest question that is in many people's minds is, given that the primary endpoint and the endpoint that we've got so far is just disease-free survival and not overall survival, is this a meaningful enough difference to lead to standard of care treatment now? David, what are your thoughts on that?
Nate, I think that probably is the question that's been discussed the most. I am certainly aware of the adjuvant trial results as it relates to overall survival. However, I think that the magnitude of the benefit of adjuvant Tagresso in this setting, even if it changes, and I think it'll narrow over time. I still believe that likely the overall survival will be statistically significant. But to be fair, we have to see what what plays out. I will also make the point that in our patients, when you talk about recurrence, that's what the we as the thoracic surgeons are talking about with them. They're very interested in recurrence-free or progression-free survival. So I think it's a clinically meaningful endpoint, although I acknowledge that most adjuvant trials have used overall survival as the primary endpoint heretofore.
Yeah, I think everyone agrees that overall survival should be the gold standard for proving benefit. However, it in a situation where even in stage 4 disease, the average survival is now multiple years, it's going to take a long time before we see the overall survival difference, if there is one. And many patients are going through surgery now and don't necessarily have time to wait. So I think accelerated approval based on a surrogate endpoint is very appropriate, keeping in mind that final approval will rely on the overall survival endpoint. But in the meantime, I agree with you. When I sit down and show these curves to patients when I'm having these discussions, this is a very easily understood concept. Does the tumor come back or not? And even if ultimately it doesn't prolong how long they live, patients are very interesting and find this compelling.
Nate, I had a question for you. When we look at these curves and see the, you know, very important progress that we've made in terms of progression-free survival, an often overlooked fact is that many of these patients, particularly the stage 2 and stage 3, had also adjuvant chemotherapy. And so some of my colleagues have said, do we even need to give chemotherapy anymore? Or can we just go straight to targeted therapy? What's the data tell you about that?
Well, it's important to remember that in the study, patients were recommended to get adjuvant chemotherapy if it was appropriate for their stage, including so most people with stage 2 and stage 3A did get adjuvant chemotherapy, and we know from the LACE meta-analysis and multiple phase 3 trials that there's a proven survival benefit in this setting. And so I think until we have a study that doesn't include chemotherapy in this population that shows that you don't need it, then we are compelled to offer this for our patients, even in the setting of an EGFR mutation and the ability to use osimertinib.
I agree. Nate, thank you very much. I just wanted to have a few words about recurrence and disease-free survival as it relates to brain metastasis, which we know is a real problem in recurrence for resected lung adenocarcinomas. So here's just a slide that shows the types of disease recurrence in the two patient populations. And I think that an immediate thing that you need to look at is that, when you look at disease recurrence or death, 11% of the patients in the osimertinib adjuvant arm had that versus 46% in patients in the placebo arm. And in the osimertinib arm, the majority of patients with recurrence had local or regional recurrence, whereas only 38% of patients having metastatic recurrence compared to 61 in the placebo arm. So there's no question that osimertinib definitely reduced the incidence of distant metastatic disease compared to placebo control. And when you look at where this disease is occurring, one of the things that stands out immediately is the difference in the brain. Uh, in the placebo arm, 10% of patients developed recurrence in the brain. Only 1% of patients developed a brain metastasis when they were on osimertinib. And I think it's fair to say that this the data is uh, maturing. We don't have the complete answer, but it definitely looks very strong in terms of reducing the risk of CNS recurrence. And you can see here in this Kaplan-Meier curve, again, maturity only 7%, and of that, osimertinib is only 2%, placebo is 11%. So data is still evolving, but there's a strong signal again, that patients who have osimertinib have a much lower likelihood of developing a CNS recurrence over time.
Yeah, I agree. I think that's one of the most compelling arguments for using a drug like osimertinib in the adjuvant setting is we know that the older drugs that were tested, like gefitinib and erlotinib, tend not to penetrate into the CNS very well. Whereas in stage 4 disease, we know osimertinib tends to work about as well in the CNS as it works everywhere else. And the ability to prevent recurrence within the brain is one of the sort of hypotheses for why osimertinib may be a better option. So I think this just makes this a more compelling result. It's also important for us to talk about the difference in people in terms of postoperative chemotherapy use. Um, One of the potential criticisms that was given to this trial when it was first presented was the overall number that only 60% of people on ADAURA received adjuvant chemotherapy, which we know, again, has a proven survival benefit. However, what we see with further release of data is that the use of adjuvant chemotherapy was highly stage specific, which of course makes perfect sense. For patients with stage 1B non-small cell, where there really is no good level 1 data supporting the use of adjuvant chemotherapy, only 26% of people received adjuvant chemotherapy in that stage. But for stage 2, there was 71% use of adjuvant chemotherapy, and for stage 3A, 80% of people received adjuvant chemotherapy. And while one might argue that for a clinical trial you could mandate this use, I think this is probably much more reflective of a real-world population. And in fact, in my experience, this is probably higher than people in the real world would get adjuvant chemotherapy. And again, when you look at the outcomes from ADAURA in those who did and didn't get adjuvant chemotherapy, you can see that the benefit seems to be the same. About 89% of people are free of recurrence at 2 years, whether you did or did not get adjuvant chemotherapy. Although because most of the stage 1s are in the group without adjuvant chemotherapy, there is a lower recurrence rate in the placebo arm in that.
This is very interesting, and I'm interested to see if it's going to hold that they're uh, particularly in the 1B patients. Is there any value really to giving the chemo? What do you tell your patients when they have an EGFR activating mutation, completely resected, and they have pathologic stage 1B disease?
Well, this actually has come up a number of times. You know, this is a group where occasionally, based on NCCN guidelines, we do discuss giving adjuvant chemotherapy based upon certain risk factors such as visceral pleural invasion, solid tumor histology, which is higher risk, lymphovascular invasion, things like that. But for the most part, we usually don't offer adjuvant chemo in this setting. But now we have a fairly significant difference in disease-free survival with the use of osimertinib, and again, calling up the difference in recurrence rates on the paper. I usually just explain what the curves mean, and patients find that very compelling. So in my experience, most people have chosen to go on adjuvant osimertinib even with stage 1B. But I agree with you that this will be the group that is most important to really see if there's a difference in overall survival because the risk of recurrence is much lower.
Yeah, I agree with you.
So next, I think it's important for us to briefly discuss the patient-reported outcomes from the ADORA study. Whenever we're giving someone adjuvant therapy for multiple years that has potential toxicities, we want to make sure that we're not potentially harming those that are already cured and may not benefit from this. And of course, those who may not be cured and later will recur, also potentially harmed by treating them earlier than they otherwise would be. So the quality of life in both arms was followed on ADORA using the SF-36 instrument. The baseline quality of life scores were well matched between the two different arms, which was important to show, although it makes perfect sense. But importantly, and this is the most important slide, for those who did not recur, because we know that those who recur have a worse quality of life, but this is everyone who does not recur, whether they got a placebo or osimertinib, and there was no difference in quality of life measures between the two arms. So despite the fact that there are potential side effects, again, most of them grade 1, with the use of osimertinib, it did not seem to impact quality of life. And so this is something that you can discuss with your patients when you're thinking about giving them multiple years of treatment and they wonder whether this is going to impact their functioning or not.
At this point, I'm going to maybe switch gears and talk about some other trials that are ongoing and looking at targeted therapies in early stage lung cancer, including in the neoadjuvant space. And to that end, I want to start with really NeoAdora, which is a phase 3 study looking at the benefit of treating patients with biopsy proven EGFR mutant non-small cell lung cancer. Again, exon 19 deletions or exon 21 point mutations with a neoadjuvant EGFR directed therapy. And so again, here we have stage 2 to 3B non-small cell lung cancer, biopsy proven EGFR mutant, as I mentioned. There is some stratification uh, for stage, non-Asian versus Asian, and which activating mutation they have. And you're randomized to one of three arms, placebo plus chemotherapy for 3 cycles. The second arm is osimertinib plus chemo, again, for 3 cycles. And then the third arm is osimertinib alone. All of those patients go on to surgery. The major pathologic response as well as the pathologic complete response are assessed. And then decisions are made regarding adjuvant therapy, but they're investigator choice, meaning can choose based on the best available data and NCCN guidelines. And then event free and overall survival are followed. So, really, an opportunity to look at how well EGFR mutant tumors will respond in a neoadjuvant setting, and will that impact pathologic findings as well as clinically important metrics of event free survival and overall survival. Another trial that's important to talk about that's just opening in North America is the Lung Cancer Mutation Consortium Trial 4 or LCMC4 leader study, which is a registry study of 1,000 patients looking at identifying before any treatment whether they have an activating or targetable mutation in the tumor. And then, if they do, following this screening study, they are offered a targeted therapy. One would be EGFR targeted therapy, ALK, ROS1, a MET targeted therapy, BRAF, a RET. If you don't have a targetable alteration, then you could be given a checkpoint inhibitor or a checkpoint inhibitor now, obviously with chemo. With the overall goal of the screening trial is to see how effective it really is to get enough tissue to perform molecular analysis, and two, how effective these therapies may be in a very small subset of patients, which would allow for a personalized treatment approach for again stage 1B to 3B uh, patients with lung adenocarcinoma. So with these, maybe I had a question in going through these earlier that I wanted to ask you, Dr. Pinnell. Do you think that the leader trial is going to how transformational could it potentially be for now giving patients targeted therapies on the front end before their surgery.
Well, I think that there's a lot of important aspects to the LCMC4 leader study. First of all, the message is that this is just the beginning, that we are just entering the targeted treatment era for non-small cell lung cancer patients. We know that there is a big disease-free survival benefit in the EGFR space. Over coming years, we'll learn more about overall survival. But we know that EGFR is only the first of the driver oncogene subsets of lung cancer that has a proven benefit. And so jumping immediately into investigating all of the targetable oncogenes, I think makes the most sense because these take such a long time that it's important to get started early. The other really big thing that I think we're going to learn from the leader study is how do we set this up from an infrastructure operational standpoint to do this? Right now, I think most people are not testing for driver oncogenes and genetic alterations or even necessarily PD-L1 in their early stage patients. It's one thing to say, well, it's not that hard for us to incorporate EGFR testing after surgery because there's time. People are getting adjuvant chemotherapy before they go on to EGFR targeted therapy or even PD-1 therapy, if we're going to talk a little bit about adjuvant immunotherapy. But if we're going to start doing neoadjuvant treatment, we have to be able to identify these people before they even get surgery. And identifying those who have a wide array of driver oncogenes plus PD-L1 is not something that we can immediately say we're prepared to do. So I think the leader study is going to pilot this. It's going to start a network of centers that are going to be prepared to identify and test people up front. Hopefully, it will start the conversation with multidisciplinary teams and institutions about how to communicate about patients with early stage disease and how to identify them for neoadjuvant therapy. And when we get to the point where we actually have proven benefits and we want to start rolling this out, hopefully there will be a lot more to learn from this than just the outcomes in the individual groups.
Yeah, I completely agree with you. I think one of the challenges is going to be, putting someone on a targeted therapy before surgery, which I think they'll tolerate very well, but for a very finite period of time. And then what will happen in the adjuvant setting, which is the other side of the other side after surgery? Will those patients ultimately benefit from staying on that therapy or not? And given the small numbers of patients, for instance, with a ROS1 or a BRAF alteration, how will we ever really clinically examine it with some rigor the benefits of continuing what you started in a neoadjuvant into the adjuvant setting?
Well, one of the benefits of the neoadjuvant setting is you do get the ability to see how well it was working, at least pathologically, at the time of resection. I do, however, think this is a space where things like circulating tumor DNA and detecting minimum residual disease before and after surgery is going to be very important. We already have some data in resected early stage patients and stage 3 patients after chemoradiation, suggesting that if you can detect tumor DNA after surgery or after definitive treatment, those patients are at much higher risk of recurrence and, in fact, have almost 100% risk of recurrence if they still have tumor DNA after treatment. And this may inform adjuvant treatment and the duration of adjuvant treatment and perhaps enrich the number of people who are benefiting from treatment, but it's highly relevant to ask these questions for these rare diseases. In stage 4 disease, we actually have approval for treatments for ROS1, for RET, for BRAF, based on less than 100 patients in single-arm trials, based on response rates and disease-free survival. How are we ever going to be able to prove overall survival benefit in a randomized trial in the adjuvant setting in this space? So these are questions that I think we're going to have to continue to ask. And I'm not sure it's going to be possible to do randomized trials. But if you were to have proven survival benefits in the stage three or in the phase three setting for, say, EGFR mutant patients or ALK positive patients or some of the more common um, diseases. And you have reasonable single arm data in the other rarer types of driver oncogenes with very similar outcomes. Should we think about extrapolating? I think, certainly not ready to do that right now, but these are the questions we're going to need to ask as we move forward. This is going to be a very exciting next decade, I think, of trial results.
Yeah, I completely agree. I think one of the good things too about the targeted therapies is the toxicity profiles here to date have been very tolerable, and I think it allows us a little bit some flexibility uh, to maybe extend indications and think about other endpoints such as perhaps disease-free survival, particularly with knowing that we're never going to have a 500 or 600 uh, patient randomized trial looking at some of these less common driver gene driven tumors. So it's going to be very exciting. I completely agree.
I'm also, I have to say, very excited about the NeoAdoro study. So, if you really think about the timing of adjuvant treatment with osimertinib, patients have to be diagnosed and staged. They have to undergo resection. They have to recover from that, go through up to 4 cycles of adjuvant chemotherapy, and then usually have recovered from that. And by the time they get to adjuvant osimertinib, it is not beyond the realm of thought that they may have gone 6 months from the diagnosis of their stage 2 or stage 3 cancer before they actually see what may end up being ultimately the most effective systemic treatment for their cancer. Moving it to the neoadjuvant space potentially moves it up much earlier when perhaps it is going to be more possible to cure them by early treatment of effective systemic therapy. The other thing that I think is really interesting about NeoAdora is there is data in the stage 4 setting suggesting that combining chemotherapy and osimertinib may be beneficial in the stage 4 setting. And so it's interesting to think that that might also end up being true in the adjuvant space, neoadjuvant space. So I thought a lot of important next steps being moved forward in this. So right now, what we currently have is only, again, the beginning and not necessarily going to end up being the standard for forever.
I agree. And I think the other important point about the NeoAdora study is the ability to look at the resected specimen and the biologic correlative studies that will be done for these persister cells, these cells that are still there after treatment with osimertinib, and giving us a glimpse into their biology and how we may ultimately end up targeting them, realizing that there's a certain selected group of cells or persisters that are still there despite adequate treatment with osimertinib. So I think there is a discovery part of these of all of the trials, but just focusing on the NeoAdora, that I think will be very informative and will drive subsequent targeted therapies and treatment paradigms.
Yeah, completely agree. We're still very early in this space, even though it's already very exciting.
Nate, that was a terrific discussion. Let's as we're winding down, let's move to some case studies. And let me share with you this one. We have a 58-year-old male, had a clinical T3N1M0 mass in the right upper lobe, so clinical stage 3A. Got a biopsy, confirmed adenocarcinoma, went on to have endobronchial ultrasound staging of the mediastinum for the stations listed here, 4R, 2R7, and L4, and they were negative. He got 4 cycles of carboplatin and pemetrexed, and then had a restaging PET scan that showed a very good response. And then the patient had a VATS right upper lobectomy and mediastinal lymph node dissection. And the final pathology showed a YPT2A N0M0 tumor. And the molecular pathology report, which came about 2 weeks later, showed an EGFR exon 21 point mutation. So this is not an uncommon scenario, I think, and maybe a few questions for discussion. Um, Maybe I'll take the first one, and then when I ask you the rest of them, when should the surgeon discuss the possibility of adjuvant therapy? And I think surgeons may not have talk too much about adjuvant therapy given the limited benefits based on the LACE analysis, meta analysis, and other phase 3 trials. But now I think we have to rethink that. And so I tend to talk about adjuvant therapy when I meet the patient and we're talking about their operation and how we'd like to do that, meaning which approach and what to expect afterwards, which may mean some adjuvant therapy. So I guess I'm talking to the patient about the possibility of adjuvant therapy even before we operate and not waiting until the final pathology report shows up. Do you think that's a reasonable practice?
I think so, and this is only going to become more relevant as we have more and more treatments in the neoadjuvant space. That uh, especially in patients on your clinical staging that you suspect are going to have stage 2 or stage 3 disease and are likely to need adjuvant therapy. And now maybe even we're getting into the stage 1Bs for the targeted treatments. So absolutely, the time to discuss that would be really at that treatment discussion beforehand. And I guess this will bring up the question: is do you even refer patients like this to see medical oncology before the operation? I guess if you're thinking of neoadjuvant therapy, that would be important.
Yeah, I mean, I think any patient for us who's got a T2A, even in zero tumor, we typically refer them for a consultation with medical oncology regarding the pros and cons. And definitely, if it's a larger tumor, even if clinically negative nodal disease, we would send that patient. So a T3 and zero, we're going to send, and then anyone who's got into or in one disease, we would send. So we send a lot of our patients to medical oncology, um, talking about induction therapy. But even if the patient decides not to move forward with induction therapy, they have the opportunity to talk about the role of adjuvant therapy.
I think that is going to be incredibly important to have that communication across the multidisciplinary team as more and more people may become candidates for neoadjuvant treatment, or even if they, as you discussed, are candidates for adjuvant treatment afterwards, at least the team will all be aware of them. Um, so one of the questions about this patient is, should they now receive adjuvant chemotherapy? So this is not a patient that would have been on the ADORA study because they got neoadjuvant treatment. But we know from clinical trials that neoadjuvant chemotherapy and adjuvant chemotherapy are roughly comparable in terms of their survival benefits. And typically, patients who receive one don't need the other. And so, if a patient has received 4 cycles of platinum chemotherapy before the operation, then I would not recommend going on to any adjuvant chemotherapy afterwards. I think the more relevant question here for adjuvant therapy is, should they now get adjuvant osimertinib? Again, this is a little bit outside of the perfect ADORA population because they got neoadjuvant treatment, but at the same time, the patient's initial stage was A3A, and that is what really is driving their risk of recurrence, even though they had an excellent down staging and not so much the pathologic stage afterwards. And so this is a patient I would definitely discuss giving adjuvant osimertinib based upon the data showing benefit in stage 3A patients.
I agree. It also brings to mind another point I wanted to get your thoughts on. You know, most of the time before there was any Adora trial, we looked at the pathologic report, the pathology report after surgery, and made the decision about when to refer a patient for adjuvant therapies based on the TNM classification that was there. It's a little different now because the molecular pathology reports, which will have the EGFR, the ROS1, maybe the PDL1, et cetera, maybe come a couple weeks later. And so in this case, for instance, if you only looked at the pathology report and they had already had induction chemo, you'd look at they were node negative, look good, not going to offer them anything. But when the molecular pathology report comes 2 weeks later, and they have an EGFR activating mutation, it's a different game now. What do you think about that?
Oh, this is an incredibly important question, and this is something we're dealing with right now as we're having discussions with our surgeons about how to identify people who are candidates for osimertinib. And there isn't, so I would say there isn't an easy answer within the current structure of how things work because, surgeons are busy. They've already reviewed the pathology report. It's hard to expect them to then go back, 3 weeks later and look at the addendum that shows that they have an EGFR mutation. So I think a better solution would be to have really a kind of an overall infrastructure to monitor these patients throughout the course of their treatment, from the initial biopsy through the end of their adjuvant therapy. What we're doing at the Cleveland Clinic is we have a patient navigator who actually reviews all pathology reports that have a lung cancer diagnosis and are tracking their molecular results as well so that they can coordinate all of the visits that they need. And some sort of, this is something that's very well suited to like lay personnel who are trained to track this, whether it be a multidisciplinary coordinator, nurse practitioner, or even a non-clinically trained person who's monitoring these reports and navigating patients through. This is the kind of relatively complex follow-up that I think these patients are going to need going forward. This is something that the breast cancer world has been doing forever, but in lung cancer, we really probably need to be moving in that direction as well.
Yeah, I agree. We do the same here at Memorial, but even with that, it's challenging to keep track of all these reports. And what you're describing sounds like a very good approach. Let's go on to the second case. So here we have a 79-year-old woman, light smoker, has a clinical T2A and 0 mass in her left lower lobe, marginal pulmonary function studies and a performance status of around 1. Gets a biopsy, confirms adenocarcinoma. Because our PFTs are marginal, there's a quantitative perfusion scan that shows a low DLCO predicted postoperative DLCO that's 35%. She's offered SBRT but refuses, and she undergoes an uncomplicated left lower lobe superior segmentectomy for turns out a little larger tumor with a exon 19 deletion. But interestingly, there's a PD-L1 score of 10, a CPS score of 10. So did well with surgery, a little older woman. Uh, Here's some questions. First, the ADORA trial actually only included patients with a lobectomy. So any or greater, any patient who had a wedge resection or segmentectomy were not eligible for this trial. So this patient has an activating EGFR mutation. She's got a T2A tumor. Is she really eligible for adjuvant osimertinib? Is maybe question one. What would you do?
No, I think this is a wonderful illustration of the minute that a drug is approved and we learn our trial data, we're immediately confronted with someone who falls outside that and have to make these decisions. So in someone like this, which, is a real kind of patient that we would see, we know in the real world, patients tend to be older than those on trials. They tend to have more comorbidities, and we have to be able to discuss this. Nonetheless, this patient with a T2B, pathologic T2B with stage 2A, has a high risk of recurrence. And given that they have an EGFR mutation, I think they would fall well within the group that would benefit from adjuvant osimertinib based on ADORA, despite the fact that they got a segment rather than a lobe.
And in this patient, she has a larger tumor. We would certainly think about giving her adjuvant chemotherapy, even if she was EGFR wild type. Um, what do you think here? It's really a case by case, I guess, decision.
Yeah, these are the kinds of discussions and why, I get paid to sit and chat with patients about risks and benefits in the adjuvant setting. And I really enjoy this kind of a conversation because you really have to kind of take into account so many other factors for this patient. I mean, she's elderly. We don't know what her social support is. Certainly, we know that 79-year-olds with a stage 2A lung cancer probably would benefit from adjuvant chemotherapy. And so very reasonable to discuss this, although probably would be talking about a carboplatin doublet rather than a cisplatin doublet. But in my experience, probably half of people in this setting, in this age group, after learning about the potential risks and benefits and the potential difference in survival would choose not to get it. And that's certainly their prerogative after you've had that discussion.
I thought this case was also interesting because the patient does have a CPS score of 10, so it's PD-L1 positive. And given the results of the 010 study out, should she get atezolizumab as well as osimertinib or only one? I think this won't happen that often, but it will happen.
Well, this is, I think, important to point out for a lot of different reasons. So, we didn't discuss this today, but we do have now, just in this month, an FDA approval for atezolizumab in PD-L1 1% or higher patients who've been resected with stage 2 or stage 3A non-small cell lung cancer. And um, we also have the option of osimertinib in this patient. And so what we know is that the 010 study did include patients with EGFR mutations. We know that there was a modest improvement in disease-free survival in the overall population, led to the FDA approval. Um, we know that the EGFR mutant subgroup had a hazard ratio that was similar to the overall population, and so there could be a modest improvement in disease-free survival in that group, but it is not in any way comparable in magnitude to the difference in disease-free survival seen in the ADAURA study with osimertinib. And knowing what we know about the limited utility of immunotherapy or even using PD-L1 as a biomarker for EGFR mutant patients, I would not routinely be offering adjuvant immunotherapy in this population. I think osimertinib would probably uh, be the best choice.
Yeah, yeah. I think it's just these are discussions we were not having 2 years ago, which again is exciting that we're even able to have these discussions in a multidisciplinary tumor board. So let's go on to the very last case we have, which is a 67-year-old man with a VATS right-up lobectomy. Again, has a early stage tumor clinically, um, but pathologic stage, he's got N1 disease, completely resected. And the question is would you test this tumor for genomic alterations?
Well, I think knowing what we now know about Adora, then absolutely would. I think an interesting question is going to be, should we test for EGFR mutations alone using, say a PCR single gene test, or would it be better to actually do a more comprehensive panel for everything? We know that stage 2 patients have a high risk of recurrence, maybe 50% risk of recurrence. And I think it is very reasonable to test for everything, but that is very up for debate, and it'll be interesting to see some cost-benefit analyses of doing single gene tests. Plus PD-L1 would be needed in early stage patients as well. The other thing that's going to be really interesting, and I'd love to hear your thoughts on this, is, again, operationally, this is not something we're routinely doing in early stage patients, and how best to get our practitioners to order the test? Should we be having our pathologists ordering the test? How are we going to start doing this routinely?
Yeah, here at Memorial, when the patient signs consent for the operation, they also sign a consent for uh, broad panel next generation sequencing for the tumor, so it happens automatically. Um, Now, I never realized that probably is not going to happen in every site, but I do think since there are targeted therapies that are available, it makes very good sense to me to use a broader panel and not just an EGFR and, for instance, a PD-L1. I think there are other targets out there, other options for patients, and if you don't test for it, you don't know it. So again, it'll be cost, but hospitals and surgeons and their teams need to be figuring out operationally how to make this a reality for their patients.
Yeah, we also reflexively test every patient at diagnosis and have for a long time. Um, but I realize that there's going to be a little bit more scrutiny, I think, going forward about the cost of this, and we'll have to really demonstrate the value of that going forward, I think.
I agree. Okay. I think as we're winding down, I think it's important to just remember that this trial really moved biomarker testing to the forefront uh, for thoracic surgeons and those individuals involved, including pulmonologists who are treating and diagnosing earlier stage lung cancer. We talked a little bit about reflex testing, which we certainly think is important and probably needs to be a broader panel as we discussed. There are a few questions from the audience. I want to take 5 minutes if we can. Maybe we don't have that time, but just talk briefly about these. Uh, First, does liquid biopsy have a role in biomarker testing in early stage disease? Where are we with that? Can you share your thoughts, Nate?
I think liquid biopsy. So most people these days are using liquid biopsy mostly for biomarker testing in advanced stage disease, where there's a higher rate of getting actionable information. I think the biggest barrier for testing in early stage disease is simply that there's a lower rate of getting a positive result. It's not as sensitive in that setting, but the testing seems to be getting better and better. And as we are talking about moving into the neoadjuvant era, where we're not going to have the whole resection specimen to test, I think liquid biopsy is going to play an important role and probably will be eventually tested on every patient beforehand, especially in those where the biopsy material is not sufficient. I think the liquid biopsy will be much more interesting when we're moving into, again, the MRD data era, where we're looking at to see whether patients are likely cured or not after surgery and whether they might benefit from adjuvant treatment. But that's still a little ways off.
Yeah, I agree, but I think it's very promising, the liquid biopsy, particularly deciding whether a patient's going to have adjuvant therapy, but for potentially even deciding how long they need the adjuvant therapy. Um, Particularly since osimertinib is for 3 years, as was done in the ADORA trial. Um, Another audience participant asks, given the improvement in adjuvant therapy, should patients with early disease still be referred for clinical trials, or should the new standard be utilized? What are your thoughts here?
Yeah, that's such a critical question, and this is tough when you're doing clinical research in the modern era, where it seems like new advancements are coming out almost every other month. But it's important that when you consent a patient to a clinical trial and give them a chance of being on a control arm, that they're receiving the best available standard of care treatment. And so, if I would not enroll a patient to a clinical trial where their randomized control arm is not the standard of care. So, if you have a trial, um, this is highly relevant. We have a new approved immunotherapy drug in the adjuvant setting. There are adjuvant immunotherapy trials ongoing right now with control arms that don't use that drug. And I think we're already starting to see trials being halted and being amended so that that control arm does represent the best standard of care. And our patients trust that we're going to do that.
Time for a couple more questions. Someone asked, what's the optimal duration of adjuvant osimertinib therapy? We don't know what the optimal duration is, but the duration was 3 years in the ADORA trial, and I think that's what we tell our patients to plan for 3 years. Um, uh, I think how someone else asked, what regimen do you recommend for elderly patients with poor postoperative status, but otherwise had their lung cancer resected? Um, I think we talked a little bit about this, but my thought, Nate, would be that if they have a marginal performance status, may not be able to tolerate a platinum-based regimen, you may move to carboplatin, something a little easier to tolerate. But that doesn't mean that they still couldn't get single agent Adora or single agent osimertinib would be my thinking. What about you?
Yeah, that's a tough question. So you're absolutely right. I mean, we have data showing that people, even months out from surgery, can still benefit from adjuvant chemo if they require a little extra time to recover. I think that's very reasonable. Um, as we had already discussed earlier, for patients who, after hearing the risks and benefits, just don't want adjuvant chemotherapy, we could still offer them osimertinib. I would not necessarily be using the Adora adjuvant osimertinib in people who are really sick and have a lot of comorbidities afterwards. If they, I think we also want to be cognizant that the benefits of this are potentially years down the line, and you want to make sure you're not harming them by treating them. But in an otherwise healthy person who just doesn't want chemotherapy or just doesn't seem to be a candidate for whatever reason, renal insufficiency or something like that, then absolutely could have a discussion about the osimertinib.
Nate, I just want to thank you for taking the time to go over this important topic of what Adora has done in terms of adjuvant therapies for early stage lung cancer. I think there are a few take home messages. First, I think as surgeons, we need to be testing, getting the appropriate next generation sequencing or PCR studies to know if the patient could benefit from adjuvant TKI therapy. And I think for me, it's important to realize that while the overall survival data is not ready yet and won't be for years, the progression free survival data and the decrease in CNS recurrence are very clinically relevant and timely and important endpoints that we need to act on now and still collect the data as it comes in. Any final thoughts from your perspective?
No, I agree, and thank you for having me on this discussion with you. I think this was a great summary of all the data, but also some real world application of this. It's an exciting time to be an oncologist and a thoracic surgeon, I would imagine as well, where in the past we did the best we could, but we knew that lots of people were going to recur, and now we're having more tools available to us that can hopefully prevent recurrences and ultimately cure more of our people that we're treating. And that this is not simply a new approved drug, but actually it's a whole system of testing, referrals, multidisciplinary care, and treatment that we're going to have to change with these new biomarker-driven treatments.
I agree. Okay. Thank you very much.
This activity is certified by Medical Learning Institute, Incorporated. This activity is developed with our educational partner, PVI, Peer View Institute for Medical Education.